And we know that these patients are challenging. They're multimorbid, they're elderly, they have a high risk of stroke, but also by virtue of the fact that these patients are treated with anticoagulants, they also are at very high risk of bleeding complications. And so managing these patients tends to be quite complex by virtue of the fact that these patients are both at high risk of ischemic events and at high risk of bleeding events. And you can see this is some data from Korea, and you can see that these patients have a high risk of ischemic events as well as bleeding events in the longer term. And this has been shown multiple times. I guess the key question around these patients is how we treat them. And one of the main drivers of how we treat them around the PCI perspective, and particularly antithrombotic regime, has come from randomized controlled trials. And hence why I suggested that Stuart may be better to talk about this. But anyway, this is the Augustus trial. And the Augustus trial is one of the key trials, which was a 2x2 factorial design, randomizing patients to apixaban and VKA, and then secondarily randomizing them to aspirin versus placebo. These were patients with non-valvular AF, and there were the regular inclusion and exclusion criteria that you can see. The primary outcome was around major bleeding. Secondary outcomes were ischemic events focused around death, hospitalization, or ischemic events. The key thing to remember is that this was not purely a PCI trial. Patients, around a third were elective PCI, 2/3 were ACS, and around a third of the ACS group were medically treated patients, and not purely PCI. This is the outcome for apixaban versus VKA. You can see that apixaban is associated with a marked reduction in major bleeding events, and the number needed to treat is 24 in this group. When you randomize for the second randomization, aspirin versus placebo, again, you can see that aspirin is associated with an increased risk of major bleeding. The number needed to harm here was 14. And so you can see that overall, the lowest event rate is in those patients randomized to apixaban versus placebo, and the number needed to treat here was 9. And similarly, when you look at the ischemic endpoints, the lowest ischemic endpoints were present in the aspirin and placebo arm. And again, the NNT was 18 here. So very much the best regime in these sorts of patients is apixaban and placebo. And we must remember that these patients were treated on average with 2 weeks of aspirin prior to randomization. We also have to see whether the differences were different in ACS or elective PCI, and you can see that there was no interaction with either ACS or elective PCI, so the findings were broadly similar in both groups. We know that patients with AF have a distribution of different ischemic risks. This is some work from my paper, from my group. And this focuses around the distribution of CHA2DS2-VASc score in patients undergoing AF. And you can see that there is quite a broad distribution of ischemic risk in these patients. The biggest risk factor, of course, being age and hypertension. And you can also see that CHA2DS2-VASc score increases the risk of ischemic events, but also increases the risk of bleeding events. So you're greater the thrombotic risk in these patients, the greater risk of ischemic events, and the greater the risk of bleeding events. However, when you stratify these patients according to either bleeding risk or ischemic risk, so bleeding risk as defined by Hasbled, ischemic risk as defined by CHA2DS2-VASc, certainly data from the Augustus trial, suggests that there's no interaction, both in terms of the safety or efficacy endpoint. So that is to say that the treatment effect of apixaban and placebo is no different, irrespective of how high the CHA2DS2-VASc score is or how high the Hasbled score is. And this has really led the European Society of Cardiology to make recommendations around the optimal treatment of antithrombotics in patients undergoing PCI. And really the default strategy here is a week of triple therapy, and that's really going to be the case as well in the 2023 guidelines that we're currently reviewing. And the standard of care will be dual therapy for 12 months and then NOAC alone thereafter. In those patients at high risk of bleeding complications, you can reduce dual therapy for 6 months. in those patients at high risk of ischemic complications, you can increase triple therapy by a month. So really, aspirin should be anywhere between 1 week and 1 month, depending on the risk of bleeding complications versus the risk of ischemic complications. How do we define the risk of ischemic complications? Well, the ESC guidelines define them both in terms of clinical characteristics, so risk factors such as polyvascular disease, diabetes, chronic kidney disease, previous myocardial infarction, as well as lesion-related factors such as triple vessel disease, long lesions, bifurcations with 2 stents, chronic total occlusions, left main, and so forth. The data from the discontinuation of the NOAC after the antiplatelet therapy after 12 months comes from the AFIRE study. So this was a randomized controlled trial, randomizing patients either to combination therapy, so in this case, rivaroxaban with single antiplatelet therapy versus rivaroxaban monotherapy alone. The previous PCI group in this patients were around 70%. Let's remember that this was not purely a PCI study, but nevertheless, when you look at both the primary efficacy endpoints and primary safety endpoints, you can see that there is a significant reduction in the monotherapy group. So the trial was discontinued prematurely because of safety concerns, and so really after 12 months, certainly in the Japanese populations, monotherapy with rivaroxaban shows superior outcomes both in ischemic events and major bleeding events. And this seems to be consistent across all subgroups studied, particularly in those undergoing PCI. So I think in conclusion, patients with AF are older, comorbid, and represent about 15% of cases. Because of their risk factor profile, because of the complexity of the disease that is used to treat them, they tend to be at increased risk of bleeding and ischemic complications. I think when undertaking these cases, one needs to always undertake the radial approach. I also think that intravascular imaging is mandatory in these patients, particularly given their high risk of stent thrombosis. Triple therapy in these patients varies between 1 week and 1 month, depending on the balance between bleeding and ischemic risk. Certainly in the European guidelines, we push towards the 1 week as the default, but you can extend it to a month depending on elevated ischemic risk, as defined by comorbidities such as diabetes, polyvascular disease, ACS presentations, and so forth, as well as lesion characteristics such as left main, multivessel disease, complex PCI, triple vessel disease, long lesions, CTOs. Dual therapy anywhere between 6 and 12 months, depending on bleeding risk. Default is 12 months. In high bleeding risk cases, you can reduce it to 6 months. And certainly thereafter 12 months, NOAC in the long term. So I'll stop there and hand over back to the panel. Thank you.